Bedside assessment of the cerebellar function. A cerebellar hemispheric lesion will produce ipsilateral signs. Cerebellar function is assessed by 1. Titubation-Nodding of head either in antero-posterior, yes, or side to side, no, direct tie-in. Sometimes, there is head tilt towards the side of lesion. Head nodding may also be seen in aortic regurgitation, syphilitic, Parkinsonism, mannerisms, anticonvulsants-induced, and mental retardation. 2. Speech, dysarthria of staccato or scanning type. The speech is usually slow, slurred and irregular, and expressed with varying force. Often the patient scans the speech, i.e., he speaks syllable by syllable with undue emphasis on a particular syllable. Ask him to say artillery or motiur Rahman, he will pronounce it as artillery or motiurra Haman. 3. Hypotonia, elicit the tone of the muscle and it will be flaccid both at rest, floppy limbs, and on passive movements of the parts. Pendular knee jerk, the patient will sit on a chair with legs hanging free side by side. Apply a sharp tap on the patellar tendon on each side, one after another. In health, contraction of quadriceps with extension of knee occurs. In case of cerebellar lesion, the knee jerks are very often diminished or pendular in nature. The first movement is followed by a series of diminishing oscillations, pendular, before the leg finally comes to rest. According to some clinicians, at least 3 to and fro movements in the leg are known as pendular. If no response occurs, never forget to do the reinforcement test. Pendular knee jerk happens to be due to hypotonia. 4. Intention tremor. When tremor appears at the goal point of an action, it is known as intention tremor. Ask the patient to hold a glass which is kept on the table or to hold your index finger which is kept away from him. The movements will be clumsy as he approaches the object. Finger-nose test also elicits intention trem. 5. Dysmetria. It means inability to arrest the movements at desired point and is elicited by finger-nose test. The patient is asked to touch the tip of his nose with the tip of his index finger, first with eyes open and then with eyes closed. At the beginning of the test, the patient is directed to outstretch his arm and the procedure is demonstrated to him by the examiner. Instruct him to look straight ahead and not to focus on the index finger. Ask the patient to repeat the test as quickly as possible. This test can be modified by asking the patient to touch your index finger after touching his nose, finger-nose-finger test. First do the test on one side, then examine the other. The index finger of the patient may fall short, hypometria, or overshoot, hypermetria intention tremor, or past pointing, his nose. By this simple test one can assess the presence of coordination and site of lesion by seeing the past pointing. 6. Dyssynergia. It is the inability to perform movements as a coordinated temporal sequences when the movements may be broken down into their component parts, decomposition of movements, producing small, jerky and clumsy movements, like the modern breakdance. The patient feels difficulty in performing complex movements. 7. Dysdiadochokinesia. The patient cannot execute rapid and repeated movements smoothly. He is asked to flex his elbows at right angle, and then pronate and supinate his forearm very rapidly as though screwing in a light bulb. It can also be tested by asking the patient to supinate and pronate his right hand over the left palm very rapidly, and then the left hand over the right palm in the same way. In cerebellar lesion the movements are slow, clumsy, awkward, incomplete, and often stops after few attempts, on the site of cerebellar lesion. 8. Rebound phenomenon. The limb overshoots beyond the normal range after sudden release of the resistance. Ask the patient to flex his elbow against resistance offered by you. As soon as you withdraw the resistance suddenly, the patient's hand tends to strike his face, because the antagonistic muscle like triceps cannot contract promptly. This phenomenon is due to muscular hypotonia. 9. Nystagmus equals horizontal, jerky nystagmus is present and the direction of nystagmus, fast component, is towards the site of lesion. 10. Romberg's sign, actually a test of sensory ataxia. The test is negative in cerebellar disease, see below. 11. Gait, A. This is a reeling, drunken or lurching gait due to presence of truncal ataxia. The patient walks on a broad base, the feet being placed widely apart and irregularly. At times, the head is tilted towards the site of lesion. Try in those patients who are able to walk. Now the patient is asked to walk along a straight line, cracks already present in the floor or you draw a line there. The patient sways and often falls towards the site of lesion during walking. Tandem gait, heel-to-toe gait. The patient is asked to walk along a straight line with the heel of one foot touching the toes of the one behind. The patient is then told to turn backwards cautiously. It is very difficult for a patient with cerebellar lesion to walk steadily by tandem gait. This gait is a sensitive test of early ataxia, a test of vermis of cerebellum. Presentation with cerebellar lesion. Connections, afferent fibers, reach the cerebellum floor, spinal cord, vestibular system, basal ganglia arid cerebrum. Cerebellum influences the LMN through its connections with the basal ganglia and cerebral cortex, via the thalamus. The common presentations are Hemispherical lesion. Paralysis is not a feature of cerebellar disease, rather the patient presents with ipsilateral hypotonia, weakness, incoordination, ataxia, and difficulty in walking or swaying while walking. Lesion at vermis produces truncal ataxia and the patient feels difficulty in sitting up or stand-ing. Lesion at flocculonodular region produces vertigo, vomiting and gait ataxia, if they extend to the roof of fourth ventricle.